So a lot of you have probably, I would say quite a few of you have probably met me before, but for those who haven't, my name is Misbah. I'm a key account consultant or an account manager for XIEL. For those of you who don't know XIEL or who aren't familiar with us, we are a distribution company in the UK for radiotherapy equipment and thermoplastics, which is what this webinar is about. So we are doing the webinar today on the Orfit masks, and we have two speakers today. So we have Rachel from St. Luke's. So she's going to be presenting on the open trial that St. Luke's have done using the Orfit masks. And we're also going to have Stephanie, who works as a product specialist for Orfit, who will be doing a product demo at the end, and we'll have a short Q&A as well to answer any questions either for Rachel or for Stephanie. So we'll get started. So we're going to start with Rachel, who's going to present the findings of the St. Luke's trial on the Orfit masks. So over to you, Rachel.
Thank you very much. My name is Rachel and I work as a radiation therapist in St. Luke's Hospital, which is based in Dublin in Ireland. So we're just going to quickly, no disclosures, and for this trial the masks were kindly provided by Orfit Industries, but they had no input in the study design or analysis that was carried out. So here we designed a patient head and neck open trial. So it was a phase 3 trial comparing closed versus open face masks. So the background was this, that a lot of patients had reported to the clinicians here that there was a lot of mask anxiety. As much as 26% of head and neck patients reported that they were having issues when they were wearing the masks for their treatment. So the background was, first of all, we published a paper where we retrospectively looked back at patients who had open masks. The reason for these open masks was mainly due to claustrophobic patients or some of our pediatric cohort. So we looked at these to see if they had the same setup data and if we were happy to continue to use these masks. And this was a paper that was published back in 2024. Then shortly after that, Surface Guided was introduced to our department here. As many people know, that the Surface Guided works to monitor the patient during treatment, and it can reduce the treatment setup times, and it can help with ensuring the patients are nice and still during treatment. So with this introduction of this new Surface Guided into our department, we felt that it would be a good time to look at the open face masks a little bit more. So we trained our staff in the Surface Guided. It was just introduced to 2 of our LINACs to start with. And we had to have a look, if we were going to use the open face masks, what was the best way to design our ROI, our region of interest. So we felt here that we would use a face ROI for the initial setup, and then when we put on the Orfit, we would use a composite ROI for the real-time tracking during the radiotherapy. So this we used to make sure we had deltas that were just within 2 mils and 2 degrees on our rotations, and all our patients were set up with the same region of interests. So here's just an image of the 5-point closed mask. So all our patients were randomized into 3 arms. So arm A was more of a traditional 5-point closed mask. Arm B was a 3-point open mask. And as you can see, we didn't have any immobilization even around the shoulders. And arm C was a 5-point open mask. So it was open across the front anterior cervix and the immobilization around the shoulders in this one. So we've randomized over 200 patients. And these are just the preliminary results. We're still working on them. So as I say, it was all radical patients who were having radiotherapy to their head and neck. We decided to exclude patients with known claustrophobia. We were already offering this cohort of patients an open face mask, and if we did know of any claustrophobia, we felt it wouldn't be fair to have them in the trial in case they got randomized to the closed mask. It was a randomization 1:1:1, and we used Python scripts to help analyze the data. So the patients were screened when they met the consultants at the clinics, and then on the day of CT, they were randomized into one of these three arms. So the primary objective of this trial was to compare the setup accuracy using the three different types of masks. And our secondary objective was to compare the patient's distress level at the beginning and the end of the treatment, with additional questions on comfort, tolerability, and overall experience. We also wanted to evaluate the advantages of surface-guided radiotherapy as a tool for interfraction motion compared to the CT imaging. As I say, this was something new that was introduced into our department, so we wanted to look at that. And then we just wanted to see if it impacted on the treatment setup time and the resources on the treatment unit. So the primary endpoint, the interfraction motion, you can see here there was no statistically significant differences across the vert, lat, or rotational dimensions among the three arms, except a slight increase in the long dimension on the arm A, which was the fully closed mask. This was larger than on the open face group, but the difference did not translate into differing PTV margins between arms. The interfraction motion, the open face masks showed interfraction stability compared to the closed masks. The mean cone beam deviations were less than 0.4 mils and 0.2 degrees. The cone beam interfraction margins were 1.8, 1.7, and 1.3 millimeters, and the margins were consistent across all three masks, which was validated by our SGRT data. And the SGRT data revealed transient deviations that were missed by CBCT. Then when we looked at the patient experience, we used the GHQ-12, that we had a 92% questionnaire completion rate. We looked at it at the start of radiotherapy and at the end. And you can see here the figures for the patient distress for the closed arm was 45%, as we would imagine, as the mask was fully closed. The 3-point open, 27%, and the 5-point open was 30%, 32%. And you can see there, at the time of doing these data, arm A had 48 patients accrued, arm B 47, and arm C 41. So it was a fairly similar number across each arm. And then the patient experience, we did the questionnaire at the start of radiotherapy. The 3-point open mask rated the best. For tolerability, the 3-point open mask was significantly higher ratings versus the closed and the 5-point open mask. And for the overall experience, the 3-point open mask was significantly higher ratings versus the closed mask. And then for the patient tolerability, the 3-point open, arm A was significantly better than arm B was better than arm A. And for overall experiences, both open masks rated significantly better than the arm A, which was the closed. So you can just see all the figures there on the right-hand side of the screen for each of the different arms and each of the different scores: comfort, tolerability, and overall experience. And then at the start versus the end, we wanted to see, did the mask tolerance experience improve during radiotherapy? And the open masks maintained a better overall rating. The 5-point open mask improved from the start to the end of RT, There was no significant improvement in the closed mask, which was arm A, and the 3-point open arm B maintained highest proportions of positive and very positive ratings across all questions. So then with looking at the resource utilization, we were looking at the number of cone beams per patient, and all these patients had daily imaging. And then if we needed to replan any of the patients during their radiotherapy treatment. So the average number of cone beams per patient per arm was 1.2. There was no difference demonstrated in the setup rate due to the mask type, but the number of the replans was lowest in the 3-point mask. So quite often replans were required for weight loss, and we noticed that the ones where the mask was open, we were able to reduce the number of replans in this one. So it was 16.7 in arm B, which is the 3-point open, versus 25% in the closed. When we were doing these replans, some patients did require a change in the mask. So 3% of patients actually went from open masks to closed masks for the replans, but the opposite is in 13% went from closed masks changed to open masks when the replans were done. But I say these weren't claustrophobic patients that we had put onto the trial originally. So the conclusion then from all our data that we'd looked at was the 3-point mask was superior. And the reason we felt this was because it improved patient experience, it had equivalent setup accuracy, it reduced the replans that we had to do here for patients during their treatment, and there was no additional setup cone beams required. And we feel this is a big benefit in our department, especially because we have a large cohort of paediatric patients here, and we're the only centre in Dublin who treat the paediatric patients. So we didn't include any paediatric patients in this trial, but the data is very favourable to use more open masks for this cohort of patients. Thank you very much.
We're just going to swap over to Stephanie now, who is going to do a mask demo and tell you a bit about the features of the Orfit masks.
Thank you, Misbah, and thank you, Rachel, and welcome in the demo room at Orfit here live in Belgium. Today, I will give you some more information about our open face masks and the related products, such as the base plates and the required head supports. So here I have our two open face masks. So on my right-hand side, we have the open face mask with a small aperture, so where the eyes and the nose are exposed, but the mouth is covered. And on the other side, we have the open face mask with a big aperture, where we have the eyes, nose, and mouth open. All our open face masks exist of 2 layers. So you can see that here. We have our bright yellow material, which is the efficacy layer, and then a reinforcement layer that is made out of nano material. So as you might know, whenever you get a hole in the mask, the stability will slightly drop. So to make sure that these masks offer the same stability as a closed mask, we added these reinforcement strips to the mask. So in the end, they will have the same stability as a closed mask. So we have the 3-point versions of this open face mask, but of course, we also have these masks available in head, neck, and shoulder versions, so the 5-point masks. The masks that I'm showing here are adult masks. We also have a full range of pediatric masks. So the open face masks are also available in smaller sizes that are suitable for use with children, actually. So to set up a patient, of course, we need our board that is compatible with our open face mask. So the open face mask, they come with L-type profiles, so the Orfit profiles. that fit actually on any Orfit head and neck base plate. And the base plate that I have here is our all-in-one base plate, so part of our all-in-one solution. So of course also suitable for brain, head and neck treatments. So all our masks, including the open face masks, can be used with this base plate. In this base plate, you see we have an embedded comfort cushion for extra patient comfort. So to position the patient, of course, we need a head support. And here I have the 6 different head support models that are in the Orfit product range. And actually, we have 3 different sizes because these head supports, they are actually pairs. So number 1 and 2 is a pair, number 3 and 4, and number 5 and 6 as well. So these pairs have the same dimensions, but the difference is that the uneven numbers, so number 1, 3, and 5, they have these lateral flaps. So if you compare it to an uneven number, so number 2 in this case, this head support doesn't have these flaps. So the main advantage of the head supports with the flaps is to avoid actually lateral movements of the patient's head. Number 1 is actually our standard head support, and we will always try to position a patient using model 1. Whenever positioning a patient, we always ask the patient to move until the head is touching the cranial backstop. So that's also a nice feature of all our head supports. They all have this cranial backstop to make sure that the patient is in the exact same longitudinal position. And next, we will check if there is still some space left under the neck of the patient and the head support itself. So head support number 1 is the standard size. If, for example, the shoulder area of the patient is pushing in this area of the headrest, we can go to headrest number 5, because this model, as you can see, is slightly shorter here in the neck area. The width of both head supports is exactly the same. If headrest number 5 is still too wide or too big in general, we can go to head support number 3, which is still slightly shorter in the neck area, but is also less wide compared to head support number 5 and number 1. So number 3 is actually the smallest head support in our product range and is also suitable to treat children from 6 till 12 years old. We do have a smaller headrest for smaller children, which is model 8, but I don't have that here available for the demo today. So first we'll have to choose the correct head support and check if there is still some air in between the neck and the head of the patient. And to fill up these gaps, we use blocks and wedges. So we have different blocks and wedges available, different sizes. So we have 2 blocks, 1 block of 2 centimeters and 1 block of 4 centimeters, and then 3 wedges. We have a wedge of 9 degrees, 13.5, and 18 degrees. So the bigger blocks and wedges are intended to create flexion and extension, while the smaller blocks and wedges, so the 2 centimeter block and the 9-degree wedges, the 9-degree wedge are intended to fill up actually the gap in between the neck and the head support. So the way how the head supports and the blocks and wedges are indexed onto the base plate is like a Lego system, basically. So we have 2 round knobs here that fit in the holes. And if you want to add a block to fill up the gap, just add the block in between the head support and the base plate. The blocks and the wedges, they are made of carbon fiber, so they are low density material, and they are also available in an MR-safe version, which is glass fiber. So once we have chosen the correct combination of headrest and blocks and wedges, we are actually ready to mold the mask. And for today, I will use this green dummy head to show you how the mask is being molded. So to activate the mask, it can be activated in a water bath or an oven. In this case, I will use a water bath. The temperature of the water bath should be between 65 and 70 degrees Celsius, and it should be left in the water for 4 minutes. That's the minimum. 30 minutes is actually the maximum, so it can stay in longer than the required 4 minutes. Also good to know is that all Orfit masks, they have an anti-stick coating. So this means that the material will not stick to each other while heating it in the water bath or during the molding process. And it will also not stick to any materials such as the headrest, and it will not stick to the hair of the patient. That's also important. To heat it in an oven, the temperature should be 75 degrees. In an oven, it takes a little bit longer, up to 12 minutes to heat this open face mask. So the mask was already in my water bath, so it's already Ready to start the molding. I will flick it out. Quickly towel dry it. I will position the hole on the dummy head. Make sure that the eyes and the nose are exposed. Stretch the material. Lock the L-type profiles in the base plate. I'll first do the lateral ones and then the cranial one. And next, I will mold actually the chin area. So in this case, I have the mask with a small aperture here on the dummy head. This mask is not compatible with SGRT systems because the hole is not wide enough and the camera will not be able to track enough of the patient's skin. The open face masks, as Rachel already showed during her presentation, these are compatible with SGRT and require a special technique to mold it. Actually, 2 persons are needed to do this, or it's easier to do it with 2 persons. Then you just let the material slip a little bit towards the hairline to make sure that the hole is wide enough so the camera can track the skin of the patient. So to ensure that the mask will be stable, you need to leave the mask on the patient for 10 minutes. During these 10 minutes, a CD scanner can be taken, so you don't have to wait just for these 10 minutes next to the patient. But those 10 minutes are very important because all Orfit masks, they have an engineered shrinkage, so meaning that they will shrink until you have actually that requires stability for a radiation therapy treatment. Thank you. And if you should have any questions, please leave them in the chat.
Perfect. So we'll just move to a short Q&A session now. So I think we do have some questions in the chat already. So let's have a look. So one for Rachel. How did you handle the patients requiring bolus for head and neck treatment immobilized in an open face mask?
We use 2 different types of boluses here. We have customized wax that we can make, or one of our sister centers has a 3D printer for making bolus. So depending on where the bolus was needed, did the bolus still fall on Orfit material or did it actually fall on the skin, decided which bolus we were going to use. The majority of patients who needed bolus, that was still on Orfit material, so we were able to use the standard customized wax. But if we did have, I think we only had 2 cases of 3-point open ones where the bolus was required in an area that was open, we used our 3D printed bolus. And then as usual, we were able to verify the position using our cone beams. They were daily imaged with cone beams, so we were able to make sure that the bolus was in the right place from the cone beams.
Just a nice bit of product placement there as well. Just anyone who's looking at adaptive 3D printing, the St. Luke's network, the 3D printing that they're using is the adaptive system that we also provide. So just to slip that in there. Another question for you, Rachel. So was there any exclusion criteria based on the location of the primary PTV? Did you include patients where the GTV was very superficial or extended up into the nose, for example?
Yeah, no, there was the only exclusion criteria was claustrophobia. We didn't look at tumor site when they were recruited at all. And sometimes even we had some of our colleagues in the clinical trials unit here helping us with the recruiting project, and they didn't even have that data to hand at the time when they were recruiting them. They just knew that they were having treatment in the head and neck area. So no, we didn't look at it. We didn't find any issues then, and they were a vast majority of different sites within the head and neck region.
And just a separate parts to that question, do you have any ideas about why the replan rate was slower for the 3-point mask cohort? And for the patients who were replanned, what was the rationale for changing from open to closed or vice versa?
I think the replan rate was lower in the 3 point because some of it was to do with weight loss. And we were able to then use our surface guided to help us combat that weight loss without having to go back to CT. So we were able to use the surface to capture for all future fractions and then set up to that new surface. So we weren't necessarily trying to replicate the CT surface anymore. We were setting up to that daily weight loss surface, where when they have the Orfit material over their shoulders, we couldn't do anything about the skin surface underneath, if that makes sense. So that's why I was on the unit treating at the time more than involved in the actual trial. And that's why I think it was lower in the 3.1s, because it was mainly weight loss that was the issue and we could work around it on the unit better. And then the reason that they went from open to closed or vice versa, open to closed was when we had problems with the shoulder positioning, because you could see in the initial picture we didn't actually have any immobilization under the shoulders, so it could be quite tricky sometimes to get the shoulders into the right position if the shoulders were relaxed back or a little bit higher or lower. So again, we used our postural videos to make sure that the shoulders were in the same place. But I think that's why in those cases when they went for replan, it was because of shoulder position. So that's why they were deemed better to go into a closed mask. And the reason that some patients went from a closed mask to an open was the patients requested it. They had realised that they wanted to be in one of the other options that was available.
And how much, I guess we've kind of touched on this a little bit, how much of a role do you believe the surface guidance technology had in leveling up the accuracy for the 3 different mask configurations?
The surface guided was really only for two of the arms, because the arm that were in the fully closed mask, we couldn't use surface guided because there was no surface there. It was all Orfit. So it was really just the two, the 3 point open and the 5 point open that we used surface for. And surface was quite new in our department at the time, and we felt it did have a big role in it.
We've kind of, Emma, I think we've answered your question about the replan patients changing from different masks, but correct me if I'm wrong. So did you use shims for all types of the masks, or for the open face, did you find there was no need?
No, we used shims for all of them. They were made in our CT scanner with a 2 millimeter T-shaped shim, and then depending on first day on treatment, but the majority ended up having that shim removed. But there, I don't have the data to see if between arms, if the shim was left in or not for more of those arms, but it was definitely in at CT and then could be taken out at unit.
Definitely one for you. Does the material stick to patient dressings, NG tubes, or any patches the patient may have on during the mask making process?
No, because all of the Orfit masks, they have this special anti-stick coating. So to make sure whenever the mask is being molded and heated, that the material will not stick to the materials, to the patient's hair, or to itself, actually.
I think we're back to you, Rachel. So do you find any issues with open face mask patients who are larger, so the chin is not so defined?
No, we didn't. We were able to, pull that, as you showed in the demonstration, to pull the material right over the chin there, and we didn't have any problems with regards to the size and shape of people. The only thing maybe was facial hair or bushy eyebrows in the open bits, but nothing to do with the size of the patient.
Was the replan rate higher than standard practice, and what circumstances triggered the replans during treatment within the trial?
I don't know the answer to the first bit, as I say, because I was more on the unit treating the patients. I could find it out because it probably was gathered in the trial. If someone wants to email me, I can check if the replan rate was higher than standard. So I don't have that to hand. And the replans would have been to do with the imaging if we felt that some of them could have been progression of disease, some of them could have been change in contour. They were just really the standard reasons that we would trigger a replan rate if based on our cone beam imaging. If there was an issue, we have a care path to follow if we have an issue with imaging.
I guess this next one is kind of one for both of you. So just regarding the reinforcement strips, so I guess the inside layer, Stephanie, does that have any impact on dosimetry slash bolus effect with the extra material? So I guess, Rachel, did you find that? And Stephanie, from your perspective, just I will add to this, we do have on the Orfit website, all the IFUs for the various different masks have all the dosimetry data in them. So you could look at that from a physics perspective as well, but I'll hand over now.
So from my perspective, I've actually not heard that comment before. So it's a very thin layer of material. So the reinforcement itself, it's 1.2 millimeters. It's a low density material. So from my perspective, there are no issues, but I think maybe Rachel can give her opinion on this as well.
I don't think we have any issues either. We've used Orfit materials here for a long time, so we've had a combination of different masks, and we've even had the hybrid masks that have even more reinforced strips in them, and we've had no issues that I'm aware of.
Has any patient ever had an allergic reaction to the mask due to the material? If so, what's the solution?
Again, I've never seen anyone to have any reaction. We've been using them for a long time.
Stephanie, have you heard of any?
No, I've never heard about it either.
No, me neither, to be honest. Which is great news because we don't want that. So just going back to the questions on SGRT, would you be confident that the setup for open face masks without SGRT would be as good as conventional masks?
That's actually the next thing that we're going to look at, because unfortunately we don't have SGRT on all our Linacs here. We're waiting for equipment replacement and we will be getting it, but we do have Linacs that don't have it. So it's very difficult for us to put all our patients onto the Linacs that do have it. So that's the next thing we're going to be looking at now. It's kind of life after open trial, how to move this forward in our department here. And we will be looking to see if the equivalent can be achieved if these patients do go to Linac with no SGRT. So at the moment we don't have the answers, but that will be our next trial that we're going to do.
Maybe I can add something to that as well, because the open face mask, also the way how it is molded has an impact on the stability. So whenever using SGRT, the hole should be a little bit wider so the camera can track the skin of the patient. For those centers that don't have SGRT, we recommend to keep the hole as small as possible, right above the eyes, next to the eyes and below the mouth, to make sure that the mask is stable enough and comparable to a closed mask.
Have you had experience using the open face masks or SGRT with mouth bites? And what's your experience with that, if so?
Yeah, we use a lot of mouth bites, but we tend to use stents rather than mouth bites that might be external. So all our patients attend a dental hospital. So I'm not sure if it's different practices in different hospitals, but most of ours are stents that are fully inside the mouth. So again, it doesn't cause us problems with SGRT. I'm not sure if you have mouth bites that are more external, if that would cause a problem. But my experience here has always been an internal stent.
That would actually be an interesting thing that maybe I'll catch up with you about, actually, because I believe you're moving to the bite locks that we
Yes,
sell.
but they're not on the machine with the surface guided.
I
Because
see. Okay.
yes,
Okay.
they will
Because
be
of that.
those.
Okay.
Yeah, but it's not just because of that. It's just because of capability slots on the machines.
Okay. So that makes sense. How does the material react and respond in scenarios involving mask adjustments? For example, using a heat gun to expand the mask in specific areas. Are all of the side pieces pre-attached, or are there versions of the mask with removable side pieces?
So whenever there is an issue or the mask should be reheated, that is possible because all Orfit masks, they have a 100% memory. So there are actually two options. The entire mask can be put back in the water and be reheated and remolded, or whenever a small piece has to be remolded, for example, you should stretch it a little bit more. For example, you can heat it in one spot using a heat gun. That is definitely possible.
I wonder actually, Stephanie, could we put the one that we've molded back in the water bath to show how well
sure.
it goes back while we've finished the rest of the questions? Thank you.
Yeah.
And answering these other side pieces pre-attached, can I just ask, do you mean the grey pieces along the side? So then for the next question, for the claustrophobic, okay, yes, so the grey pieces come attached to the masks already, yeah. They just come like that to you. I don't believe we do make ones with removable side pieces, but correct me if I'm wrong, Stephanie.
No, that's not available.
So for the claustrophobic patients, would you advocate the use of open face masks even without SGRT and CBCT, as opposed to medicating with full face mask for treatment?
Yeah, so before we had SGRT, we've always used open face masks for patients who are claustrophobic. The OROs, the radiation oncologists here are much more in favor of using an open face mask rather than medicating. So that initial paper that was mentioned at the beginning of the talk was a study that we did prior to having surface guided, and that was a retrospective study of a lot of patients who had had open masks either because of claustrophobic or because they were pediatric, and sometimes with ventilation tubes we had to have it a bit more open to get all, because they could be under general anesthetic and things. So that was a study that was done before this, and the paper was published, and it did show that we had very good results from open face masks and cone beam without surface guided.
So, Rachel, do you make the shells on day 0 before CT, or do you make them on the same day?
Sorry, we make them on the same day. So we all, the patients, and quite often they've even seen the doctor on the same day. So they come to see the doctor, their consent is done. In these cases, that's when they met someone from the clinical trials unit, was randomized. And then we make the Orfit in our CT scanner and then carry on and do the scan.
And just another one, what is your CBCT tolerance with online imaging?
So 0 tolerance, because we take all the moves and make it perfect.
Amazing. I think that's it from the Q&A as well. We should be nearly there with the mask. So
and we had a 6-off bed as well, so we were able to take 3 degrees on the pitch roll and rotation as well, up to 3 degrees on those as well, because it was the Linac that these patients went to had a 6-off couch.
Are there different sizes of the masks available for pediatric patients?
Yes, we do have 2 sizes available. We have the small size for children from 0 to 5 years old, and then we have a medium size for children from 6 to 12 years old. And then, of course, the adult versions.
Okay, perfect. If you think we'll be nearly ready.
Yes, absolutely. The mask is
amazing.
ready.
Thank you.
So
okay, so we'll be able to see how they go back to normal. Basically, we should see that it's just basically sprung back.
Yeah. Exactly the same as the first time. So I'll mold in the exact same way. Attach first the lateral profiles and then the cranial profile. And next we can mold it under the chin, like this. Here you go.
Amazing. Just another question. What temperature is the water bath set to?
It should be between 65 and 70 degrees Celsius.
Yeah, the Orfit team do a really good demo at Estro actually, where those masks, we can pull them about as far as they'll go and then put them back in the water bath, and they do, even once they've been pulled to, I would say, I think Lionel pulled it to about 1 meter wide and it's still sprung back in the water bath. So if that doesn't help with recycling and all the sustainability stuff, then I don't know what will really. Particularly if you have an oven and it's not a problem to keep putting it back in. So yeah, thank you all for joining. And yeah, we'll get that recording out to you probably tomorrow or the day after, in the next few days anyway. And feel free to forward on to all your colleagues. Okay, thank you very much. See you all soon.
Thank you.